Hey everyone, this is Jackie with the El Paso Teller 911 Authority. Today we're going to be talking about Protocol 26, sick person, and when to use it, when not to use it, and a closer look at case entry and key questions. The protocol definition of a sick person is a patient with a non-categorizable chief complaint who does not have an identifiable priority symptom. This protocol is often the medical catch-all in the EMD protocol when nothing else seems to fit the patient's symptoms. This also leads to it being one of the most overused protocols. Protocol 26 calls comprise about 15% of all medical calls taken. A look at local numbers in our dual region recently indicated that that could be closer to 20%. Why is Protocol 26 overused? First, Protocol 26 is sometimes used as a baseline to choose a more specific chief complaint protocol until more information becomes available. Protocol 26 should not be used to protocol serve. Second, while it can be overwhelming when we are provided with several symptoms, I'm sure many of us can agree that we have had a medical call with a long list of symptoms and a complete medical history provided to us. This flood of information at the beginning of a call can be overwhelming and cause us to miss information. When should we not use Protocol 26? When the answer to any of these questions is yes. Are there scene safety issues? We want to remember Chief Complaint Selection Rule, which says if the complaint description includes scene safety issues, choose the Chief Complaint protocol that best addresses those issues. Keeping our responders, callers, patients, and others on scene is a high priority. Second, are there priority symptoms? Again, we have a Chief Complaint Selection Rule that covers that. Chief Complaint Selection Rule 5 says if the complaint description appears to be medical in nature, choose the Chief Complaint protocol that best fits the patient's foremost symptom with consideration given to priority symptoms. And finally, is it covered by a more specific protocol? If there is a specific protocol for handling a symptom, we want to use that protocol. When a patient has multiple symptoms and we aren't sure where to go, considering these questions can help us triage the symptoms or information provided to us to select the most appropriate protocol. Now that we've discussed when not to use Protocol 26, let's dig deeper into why these considerations are important. Scene safety issues pose a danger to responders and those involved in the call. There are several scene safety considerations, and this is not an all-inclusive list, but these are some that you might commonly encounter. Dangerous animals, drugs or drug paraphernalia, electricity, terrain or location difficulties, weapons, and hazardous materials. For example, a caller may report vomiting and feeling dizzy as their primary symptoms, which should be handled on Protocol 26. But after asking, "Tell me exactly what happened," the caller reports that they have been exposed to a hazardous substance. Sick person is no longer the most appropriate choice because we now need to consider the safety of the patient, responders, and overall scene safety. Priority symptoms. Anytime a patient is reported to have abnormal breathing, chest pain or discomfort, a decreased level of consciousness, or a serious hemorrhage, we want to remember again Chief Complaint Selection Rule 5, which tells us to choose the chief complaint protocol that best fits the patient's foremost symptoms with consideration given to priority symptoms. This rule gives you, as the EMD, flexibility in choosing the protocol that best addresses the caller's main complaint, but also reminds us priority symptoms are serious and have the potential to get worse. A quick tip as we're going through this training: for unusual calls, asking the caller to tell you again exactly what happened can help you get a better mental picture of the situation and help you focus on the symptom that's worrying the caller or the patient the most. And finally, specific protocols. There are some conditions that are best handled on a specific protocol. This can include abdominal pain, back pain, eye problems or injuries, headaches, or mental health conditions. If the chief complaint contains multiple symptoms that are alpha or omega level symptoms, but also have symptoms that are covered by a more specific protocol, go to and dispatch from the more specific protocol. For example, a caller saying that she's vomiting, nauseous, and has pain in her stomach should be processed on Protocol 1, abdominal pain. Now that we've discussed some considerations and how to triage symptoms, let's talk about when and how we should use Protocol 26. Protocol 26 should be used for specific diagnoses to include sickle cell crisis, thalassemia, autonomic dysreflexia, hyperreflexia, acute adrenal insufficiency, adrenal crisis, Addisonian crisis, and Addison's disease. While rare, adrenal insufficiency or crisis or Addison's disease are medical emergencies that require a timely response and code is a Charlie level. Most callers will identify if they have a history of the disease, similar to how other reliable diagnoses we can accept from patients are given. More information on these conditions can be found under the axioms on Protocol 26. Case entry. Now that we know when not to use Protocol 26 and the specific conditions that are handled on Protocol 26, let's start from the top in case entry. After asking, okay, tell me exactly what happened in case entry, if you were provided with vague information or a medical diagnosis, we want to acknowledge what the caller has provided and ask the question again. If you're still unable to get more detailed information, move on. You've met the standard of asking twice and can proceed with Protocol 26 as appropriate. Additionally, in case entry, caller party can help us determine if Protocol 26 is appropriate. The proximity and involvement of your caller can help. Protocol 26 should be used for patients with an unknown problem who are with or near the patient. These are second-party callers. A caller who is not with or near the patient and does not know what the problem is should be processed on Protocol 32. These would be third and fourth party callers. Moving on to key questions. Did you know Protocol 26 has a safety net? If we look closely at the first four key questions, there is a pattern. Is he or she responding normally? Is he or she breathing normally? Is he or she bleeding or vomiting blood? And does he or she have any pain? All of these questions are used to identify the presence of priority symptoms. If key questions reveal that a patient is not completely alert, the altered level of consciousness list helps us record and properly code this information. Some callers don't always answer a simple yes or no, so the various descriptors were added as a safety net. It is important to note that a patient with an altered level of consciousness will not be shunted to Protocol 31. Is she or he breathing normally? While two of the four key questions regarding priority symptoms can result in shunts to more specific protocols, which we'll discuss shortly, the breathing normally question does not. This is because data has revealed that patients' acuity tends to be lower when this symptom is discovered in key questions rather than presented as part of the chief complaint. The separation of this code on Protocol 26 allows for appropriate local response assignment that may be different than the codes on Protocol 6, breathing problems. Key question 3. Is he or she bleeding or vomiting blood? If the question is answered with yes, the call taker will be shunted to Protocol 21 for hemorrhage or laceration to finish questioning and provide appropriate PDIs. If the caller reports a minor, unrelated hemorrhage, the protocol will not shunt and you will remain on Protocol 26. This is because Chief Complaint Rule 6 says, a minor hemorrhage discovered during key questioning on Protocol 26 when clearly unrelated to a medical chief complaint should not be considered bleeding in the dispatch environment. No shunt is necessary. Key question 4. Does he or she have any pain? If the question is answered with chest pain, including discomfort, the call taker will be shunted to Protocol 10 to finish the call. All other pain reported remains on Protocol 26. This is covered by Chief Complaint Rule 2 that says the EMD should remain on Protocol 26 for symptoms other than chest pain or discomfort, heart attack symptoms, discovered during key question 4. Suppose the caller has volunteered that the patient is having pain caused by a sickle cell crisis, thalassemia, or one of the other specific conditions identified. In that case, the protocol will not shunt, but this will prompt a specific final code. Key questions 5 and 6 are operator questions. These are the bluer for you questions. Key question 5 is a list of alpha level symptoms. Two of the common selections on this list are 10 for unwell or ill and no. The unwell or ill option should only be selected when that is the only symptom provided. It should not be used as a generic catch-all. Additionally, if the patient's primary problem is not listed, we can then select no, and the omega level list will be shown on key question 6. Selecting unwell or ill from the alpha level list when the patient's chief complaint is specifically listed on the alpha or omega level list is incorrect and will give an incorrect final code. Key question 6, again, is an operator question, and these are your omega level non-priority symptoms. The no inter-problem description selection should only be used when the symptom described is not on the alpha or omega complaint list and cannot be handled elsewhere in the protocol. Selecting this code and manually entering a problem description that is already described on either of these symptom lists will result in an incorrect final coding. It's unnecessary for you as the EMD to memorize all of these symptoms, but it is helpful to maintain a general knowledge of the alpha and omega symptoms to code the call correctly. You can find all of these symptoms in the Additional Information tab at any time while you are processing the call. If you would like additional information about Protocol 26, I have included some journal articles in the IAED journal that you can read. Additionally, the IAED College Advancement Series has a specific course on Chief Complaint Selection Protocol 26. Thank you again for watching, and we hope this helped expand your protocol knowledge. If you want to test your skills based on what we learned here, please see the Protocol 26 Scenario CDE on our website and put your skills to the test. Please don't hesitate to contact us with any questions. You can email us at 911training@eptc911.org or by phone at 719-785-1900. You can also visit our YouTube channel and subscribe at El Paso Teller 911 QA Department. We upload CDEs and videos like this one regularly. You can also visit our website, elpasoteller911.org, where we upload these CDEs regularly as well. Thank you so much for your time, and we'll talk to you soon.